Assalamu alaikum. I'm Dr. Ahmed Lutfi. I'm a senior consultant obstetrician and gynecologist. I've been practicing in UK, New Zealand, and Middle East. My qualifications are MPCHB, master's degree, and MRCUG. This is the third video about hypertension in pregnancy, and we'll start with management of severe preeclampsia and eclampsia. Key principles are: number 1, prevent and control fits. Number 2, control the blood pressure. Number 3, expected delivery. Number 4, monitor organs failure. Number 6, close patients monitor. Magnesium sulfate regime if the patient is unfit. Loading dose 4 gram IV over 10-15 minutes, or intramuscular 5 gram in each buttock. Maintenance dose 5 gram intramuscularly every 4 hours. Or if the pump is available, we can give 1 gram by pump intravenous every hour. If the pump is not available, then the breakthrough fits will need 2 to 4 grams IV over 10-15 minutes. This is again the magnesium sulfate dose. Monitor during magnesium sulfate should be every 15 minutes. Respiratory rate should be more than 16 per minute. Urine output more than 25 ml per hour, and presence of patella reflexes. Complications and management of magnesium sulfate administration. Respiratory arrest is a life-threatening complication, should need intubation, ventilation, and stop magnesium sulfate. Give 1 gram of calcium gluconate. Respiratory depression, if the respiratory rate less than 16 per minute, then we stop magnesium sulfate, give oxygen and calcium gluconate. Absent reflexes, stop magnesium sulfate until reflexes return. Antihypertensive drugs, hydralazine 5 to 10 milligram intravenously, slowly, and it can be repeated every 3 hours. Labetalol 20 milligrams IV, slowly, and it can be repeated every 3 hours. Labetalol orally 200 milligram every 4 hours can be given, and other medication, nifedipine and methyl dopa, could be considered if hydralazine or labetalol are not available. Intravenous fluid management, we use crystalline, normal saline, Ringer's lactate. We avoid the plain dextrose. Rate 1 liter every 12 hours. We should monitor input-output closely. Inpatient monitoring, urine output and proteinuria. We check the signs of pulmonary edema, crepitations, and laboratory tests, urea, creatinine, liver function, platelets. Should be like every 6 hours. Fetal well-being by CTG and kick chart. Postpartum care, continue antihypertensive drugs for at least 6 weeks to 3 months. Maintain IV fluids for 48 hours. Monitor urine output should be more than 30 ml per hour. and the patient should be linked to follow-up care by community midwives. Complications of preeclampsia syndrome. First complication is HELP syndrome. The hemolysis, elevated liver enzymes, and low platelets. So this should be treated by blood products and delivery. Pulmonary edema, oxygen and furosemide, and may need renal dialysis to remove the excessive water from the body. Renal failure, IV fluids, furosemide, and refer for renal dialysis. This is the end of the presentation of hypertension with pregnancy. Thank you.